Thank you, Elizabeth. Always a pleasure to share the screen with you. I'm Peter Kilmarks. I'm the Deputy Director of the Fogarty International Center at the U.S. National Institutes of Health. I really want to thank all the presenters. What a remarkable, diverse session of excellent science. We've got some really great presentations and some good questions coming in. Let me encourage you to continue to enter questions so we can ask the presenters. We'll start with one for Gregory Chang. Greg, congratulations on a great presentation and a really topic of interest to me about alcohol and HIV, really robust findings. The question is, do you think if you look, you would see a dose response in terms of the different levels of alcohol abuse or misuse and the HIV outcomes? You just looked at a sort of a single cutoff. I'm wondering if there might be a dose response to that. And then has there been any thought about partnering with breweries and alcohol producers and distributors in testing?
Yeah, it's a great question. You can hear me okay, right?
Loud and clear. All
right. Yeah, in terms of the dose response, in the past literature, there's been association between higher levels of drinking and its effects on different HIV outcomes. But for the purpose of our analysis, it was only based on like a 3 composite question. So it was harder to kind of hash out that relationship. But we could look at higher audit C scores and see if there's a dose response there. But the max score is not very high. So we would have to see. It would be harder. Perhaps a better analysis would be to look at the whole audit question, which is a 10-question questionnaire as opposed to a 3-question. But in terms of your brewery question, I think that's a really creative idea to get people to get tested, seeing as though that's kind of the main gap in the care for men, at least. So having testing clinics or testing partners at local breweries or bars or nightclubs would be a good idea.
Terrific, thank you. And we have a number of questions coming in for Joseph Baluku, really more about the clinical implications of the positive test and of those who actually have the positive screening test, how many of them have a cryptococcal diagnosis, how many of them actually are diagnosed. And then I was wondering, given the challenges of doing the screening and the relatively high positivity, what about just having universal fluconazole, just giving everyone with a diagnosis a short course of fluconazole, since the testing seems to be so challenging?
Thank you, Peter, for those questions, and the audience as well. So, with regards to the first question, unfortunately, the sort of data that we had was programmatic data, and we did not have specifically the numbers of people who actually had cryptococcal meningitis, and therefore we are unable to report on that. I think the downside of prescribing fluconazole for everyone, the downsides are many. Number one is the adverse effects that are associated with the drug, especially hepatic injury, and the drug-drug interactions with ART, and probably there are patients who are on isoniazid prophylaxis for tuberculosis. And so it may not be cost-effective as well to prescribe prophylaxis for everyone for everybody. And of course, running the risk for resistance in case everyone who doesn't need the drug is prescribed fluconazole, as you are asking.
Thank you. Clear response. Now a question for our third presenter, Dr. Bousmah. It's impressive that it seems to be essentially a straight line, fairly equal costs between the efavirenz and the dolutegravir scenario. So it seems like whatever downside of the somewhat less virologic suppression from the efavirenz is completely counterbalanced by the insomnia and obesity, the effects of the dolutegravir. Can you just comment more. Is that correct? That basically they're just on the one hand this, on the other hand that, and it ends up being just a cost, the cost of the drug?
Yes, so thank you for your question. Actually, yes. So at first, the prices of both regimens are very close nowadays, and of course they are fluctuating a lot. So we don't know in the near future, but our analysis can provide the result for the cost effectiveness of both regimens depending on the evolution of the prices. But as of today, yes, there were no differences in prices between both regimens at 95% confidence level. Although in absolute values, the dolutegravir was slightly less costly. So this is why in our model, with the extrapolation of the results on 10 and 15 years, we see that the price differences become significant. So yes, this was to answer your question. And we of course the difference in prices that we observe over the medium and long term is mostly due to the significantly less number of virological failure in the dolutegravir arm. More than the effect of obesity, actually, of weight gain.
Terrific. Thank you.
Thank you.
And now a question for Dr. Kentusi. Again, I'm just so impressed by the diversity of these presentations and the excellence of the science. But in your findings on stigma across the 3 countries, I was very impressed at the real differences between the countries, but then even at the district level, that you had some positive versus negative stigma outcomes, even quite strikingly different at the district level. Is there any insight into, what could account for that at the district level? What the differences are in terms of, is there just better awareness, or are there some key individuals, or can you say anything more about the striking district level differences in the stigma outcomes?
Yeah, thank you so much. And just as you've indicated, the resilience scale tries to measure how much people living with HIV can cope despite the HIV positive status, how much they can cope. And in the case of Uganda, for instance, we had 6 districts, and it is these districts in central Uganda that would be able now to measure where people are able to cope despite being positive. And part of what can explain why the difference was not so much, we also looked at the amount of time the people living with HIV had spent having known their status. And since majority had lived on average 7 years, that the longer the HIV, there wasn't much variance between the districts that you find it across, whether it is Cambodia, whether it is Dominican Republic. But in this case now for Uganda, you would not find so much difference because of the time that had been spent compared to when someone has just been initiated on ART. Thank you.
Terrific. Thanks, Kate. Any comments or questions, or are we out of time?
We're right at time for the tea break.
Okay,
Great session.
Let me just close then by thanking everybody, thanking Elizabeth, my co-chair. We're going to a 15-minute break, and we'll come back after that with a symposium on innovations in prevention and treatment of HIV. Thanks, everybody, and we'll see you in 15 minutes.